My name is Phil Parker. I'm lead nurse at the National Prion Clinic in London, and together with Margaret Leitch, the National CJD Care Coordinator in the Edinburgh CJD Research and Surveillance Unit, we're going to present this evening on managing the symptoms of CJD, advice for carers. I know there's people watching who have personal experiences of caring and indeed losing loved ones to CJD, and also people who are currently caring for people with a diagnosis of CJD. So you're all very welcome. I ask you to, as Beth says, leave questions for after the presentation for now, please. And hopefully we'll all get a lot from it today. So Margaret and I decided that probably the best way to sort of put on this presentation was to start with a study that was published back in 2018 by a nurse that was part of the National Prion Clinic, who's since left, because it's a useful study in that it actually asks 71 carers what the most problematic symptoms of prion disease were that they experienced, and those people care for people with a wide range of disease severity, and were asked by questionnaire to identify the most problematic symptoms. And the most problematic domains that they identified were communication, cognition, continence and personal hygiene, mood and behaviour, mobility and coordination, and eating and drinking. And so that's the sort of 6 topics that Margaret and I have sort of focused in on for the purposes of the presentation this evening. So the first domain is communication. I'll hand over to Margaret to present this domain. Margaret, thank you.
Thank you. I'd also like to acknowledge Liz Ford for her contribution and her work that's helped us to structure this presentation tonight. So communication, which is making contact with others and also being understood when we make that contact. Thanks, Phil. So what we want to look at is the ability to listen and to write and speak and communicate, sadly, will eventually cease, but the rate is individual to each person. So when you talk to others, what you need to understand, or what we'd like you to understand, is each person's going to be different, and your journey may well be very different to someone else. And some of the things that we're going to discuss this evening will work for some and not for others. And not all the interventions that we will discuss are going to be appropriate due to individual difficulties. So trying out different systems will be important. So we're going to discuss different systems. So please feel free to write down or ask us your questions at the end, and we will talk about them, because we're only going to touch on some systems. We don't have time to go through them all at the moment, but we will have time to answer your questions at the end. What is important to all individuals, especially, is a referral to the speech and language therapist as soon as possible. And people like ourselves, like myself and Phil, will be available to do that for you at the very beginning. And that's important to have to monitor that throughout your journey. Thanks, Phil. What we find is it's really, really important to slow everything down, and that's to slow your understanding of your family member down, slow your speech down, try and slow their speech down as well, because I think all their thoughts are slowing down, their speech is slowing down, and if you can slow that down, then you can maybe understand what they're saying and what they're trying to say much easier. Manage your expectations. So manage what you're expecting them to say, and manage what you're expecting them to understand of what you're saying. The fewer words that an individual has left, the fewer words we should use. So don't use complicated sentences. Try and use simplistic language without being without the baby talk. Just use simplistic language. Be direct. Use very short sentences and short words. Don't be too airy-fairy with your sentences. Don't be too descriptive with your words. If you can repeat back to the person what they've said, just to make sure you've understood and you've not misunderstood what they've said, but in a respectful way. Try and make eye contact when you're talking to someone. You know, when you haven't understood what someone's saying to you, it's much easier to understand someone if you're making eye contact rather than when you're on the phone. And it's the same when you're sitting with someone. Try and make eye contact. Try and get other sorts of understanding from them. Be non-confrontational when you're talking to them. Sometimes if you sit directly in front of someone and you're kind of a misunderstanding what they're saying, that can be quite confrontational. Try standing side on to them or sit by their side, and they're less likely to get upset. It's much more calming. And consider all forms of communication to help. There's all forms of communication that you can use, not just speech. Thanks. When you're talking to someone, try and limit their choices. Instead of saying, would you like lunch today, and rhyming off a lot of things, it's better off to say to someone, would you like soup or would you like a sandwich? Don't say, would you like tomato soup or would you like a ham sandwich? That's what I was saying earlier. That's really too much of a complicated sentence. Try and keep it short. Try using yes or no boards, or if even that's too complicated, a simple thumbs up or a thumbs down. Try and use other cues, such as a simple hand on the shoulder for them to sit down. Now, I'm not talking about pushing someone down. I'm just talking about a simple hand on the shoulder can help someone to sit down. When you're talking to someone, or if you've got family members visiting, try and remove all the distractions around the house, you know, like TVs on, radios on, because that can be really distracting for the family member, trying to understand what's going on around. Try and keep the distractions to the voices that are around them. Don't have multiple conversations going on. Try and tell the family members that are visiting to try and only keep one conversation going on at once and direct that to the person they're visiting. Too many things going on at one time can be really torturous for that person who's trying to focus on understanding what's being said, understanding the language, and trying to keep everything nice and slow. And when you go in, it's good if you can explain to the visitor to identify themselves clearly. It's a good idea if you tell them to name who they are and their relation to their loved one. You know, just something simple like, you know, hiya, I'm George, remember we used to work together. Something really simple and innocuous. And finally, are you telling me to slow down now, Phil? Trying to just to slow everything down. Sometimes it's okay to just be there. There's no need to always speak. Sometimes you just have to hold their hand, and that's enough. Communication isn't always about speech.
That's lovely. Thanks very much, Margaret. Okay, so now I'm going to present on cognition, which is basically a fancy way of saying thinking, remembering, judging, and problem solving. So some of the sort of skills and functions that our brain allows us. So first of all, we'll talk a little bit about the progression, then I'll go on to talk about some strategies that can help. So there are various types of onset of CJD, and cognitive onset is quite common. So it might be the first symptom that you actually notice and starts ringing alarm bells that there might be something amiss. And that tends to be quite an insidious onset, starting slowly. So you might notice your loved one or the person you're caring for misremembering words, forgetting names, forgetting places. Attention and concentration can start to become impaired at this stage, and sort of staying on task and things, so people can get distracted very easily. And you may well have noticed that it's the short-term memory that tends to be affected first. long-term memory tends to be very well preserved for certainly a period of time. So people may be able to talk about things from the past, but not things that have happened that day or perhaps over the course of the last week or so. In the moderate stages of the illness, people will become increasingly disorientated to time, place, and person, and may not recognize where they live, even if they've perhaps lived there for many years, and start not being able to recognize people, which later on can become quite hurtful. But it's just if somebody's unable to recognize loved ones, maybe spouses, partners, children, and things, but it is obviously just a symptom of the disease and needs to be seen as such. And forgetting how to do things, particularly things, sequential tasks that require a number of different distinct tasks to be done in sequence, like maybe making a cup of tea or even just going to the toilet and getting all the stages of that in the right order. And then later on in the advanced stages, people will become unable to use tools and objects such as cutlery. They'll be increasingly unable to make judgments around safety and things and make choices. So limiting choices can be useful, as Margaret says, but later on in the disease, even simple choices will become impossible. And people will increasingly lose an awareness of their surroundings and just not be able to make sense of the world around them in the way that they once did. I'll have a look at some of the strategies at these different times. So at the onset, often people will try to employ tactics for kind of what we might call reality orientation. So it's helping people to sort of stay as independent as possible and to sort of manage the problems associated with the milder end of cognitive impairment. So use of things like a diary or a wall planner or whiteboard where you can write up the schedule for the day or for the week can be useful here. Labeling drawers, for example, can be useful. There's all kinds of assistive technology out there these days. Date time clocks can be useful for people who are disorientated to time. We found it's often best to stick to an analog clock because they're better understood for longer. There's a product called Memorabel, which is very useful, where you can actually sort of program things into essentially like an alarm clocks, and it flashes up graphics on the screen saying it's time to take your midday pills, for example. And that can actually be useful for carers as well, who have always got a lot on their plates and may forget particular medication administration times, for example. So that can be useful for both carer and patient. GPS trackers as well. Obviously, a lot of people have got these on their phones, and that might promote independence while that is still possible, so people can go out into the local area without the risks associated with getting lost. So, as I say, promoting independence where possible. As a carer, not necessarily sort of steaming in and taking over all aspects of somebody's life, but actually sort of picking up where the deficits start, if you like, so that people can continue the way they were for as long as possible. Obviously, driving very quickly becomes unsafe, particularly in CJD. Other types of dementias that have a longer course, people might be able to drive for longer. But given the rapid cognitive decline associated with this illness, driving is really not recommended after diagnosis for public safety reasons. And you should really notify the DVLA of the diagnosis as well. And to avoid cognitive overload, so similar to what Margaret was saying around communication, just trying to keep things short and simple, not overloading somebody's limited cognition with too many tasks in tandem. In the more moderate stages, people will require increasing supervision and prompting. This is as their appreciation of risk deteriorates along with the cognition. There is an approach known as validation, which is very useful to employ at this stage, which is in a nutshell, sort of going with the flow, and it's about not, if you like, contradicting the person's perception of reality and not entering into arguments with them about what it is that they're perceiving in the world around them, but validating their perception of reality, because ultimately you may be able to persuade someone into your way of thinking, but in the process of doing that, it may cause some upset, and the emotional impact of that may live with the person for longer than the information or that you've managed to persuade them into agreeing with. At this stage, reminiscence therapy can be useful. As we were saying, long-term memory tends to be well preserved. So while someone is still able to look at photos or other sort of memorabilia from their lives and things, that can be really useful to tap into those memories that are better preserved. Rummage boxes as well, perhaps a box with various items from around the home that can stimulate conversation and things. Music is really, really key here, and taps into some very, very long-term memories that can be useful throughout the disease. And obviously, as a carer, we need to be incredibly patient and understanding, and appreciate that it really is the effects of the disease, and it's not people trying to be difficult or awkward. It's just the disease affecting their ability to think clearly. And so gentle activity, things based on what it is that people previously enjoyed, whether that's cooking, where perhaps somebody might still be able to contribute to that by mixing something, or just sticking within somebody's sort of limitations, maybe gardening and thinking about how you might be able to provide some exposure to those things that somebody enjoyed, despite the limitations that they're experiencing. And in the advanced stages, as I said, when somebody's really struggling to make sense of the world around them, is sort of employing more of a sort of sensory stimulation approach. Again, music can be really, really useful here. There are various sensory aids which are available these days, including fiddle muffs and things which can provide stimulation to all the various senses. And touch and massage can be really, really useful here, to show somebody, that you care and love for them, and really sort of make a connection even beyond the time when they're not really understanding or able to engage in any kind of conversation. There is a technique called the M technique, which you can find on YouTube. If anyone's interested in finding out more about that, then do let me know, which is a really good sort of simple massage technique for somebody's arm and hands. And really, increasingly, your body language and tone of voice becomes important in these advanced stages of the disease, and will provide a lot of reassurance, even if someone's not necessarily able to understand what you're saying. As I say, just your tone of voice can provide a lot of reassurance and have a real calming effect on somebody. So perhaps reading out passages of books or poems and things like that, if you can't think of anything to actually talk about, so to speak. Okay, so moving on now to continence and personal hygiene, Margaret. Are you there, Margaret?
Yep, I'm here. Sorry, it keeps putting me back on mute. Continence and personal hygiene. I'm going to talk about this from the point of view as someone in the early stages, to start with, and then we'll go on to the later stages. Right, thanks, Phil. So incontinence is the inability to control the excretion of urine and or the contents of your bowel. It can be caused by the effect of prion disease on the brain itself. However, I think it's really important to always eliminate other causes, such as urinary tract infections, constipation, and the side effects of medication, particularly in the early stages of this condition, which we'll talk a little bit about in the next couple of slides. It can also be caused by the inability to use the toilet due to other causes such as poor mobility, lack of access to the toilet, and poor understanding of how to use the toilet, and an inability to ask for help, which we've covered a little bit in the previous slides. So some of the strategies are, one of the main things I think, as we touched on earlier, is a referral to the occupational therapist. And if we can get the occupational therapist involved sooner rather than later, she or he can help with some aids, which we'll mention, and the district nurse to assess for adaptations, equipment, and continence wear that we might be needing in the future. I think we want to be proactive in this rather than reactive. So it's better to have equipment there that you will need in the future than need it tomorrow and not be able to get it until next week. So if we start off with regular toileting, and that, what I mean by regular toileting is helping someone to the toilet on regular intervals, perhaps maybe 2 to 4 hours all the time, and maybe after meal times. That can help someone get into a really good routine. If we think someone's going to have constipation, you can manage that by ensuring that they've got a varied diet. Really good hydration is extremely important. And while we can, keep them moving and walking if possible. It's not always possible, I know that, but if we can for as long as possible, that's always a good thing. Keep the route to the toilet clear of obstacles. I know it sounds like a little thing, but if you can sit them closest to the door to the toilet, just simple things. Adaptations, which you can ask the occupational therapist for, are a handrail. A raised toilet seat can help with mobility problems. A commode can help if the person's unable to get to the toilet. And I've heard that the commodes on wheels, these glideabouts, have been reported as really useful by the families, because they can use them as a commode, or they can use them actually as a mobility aid to move the family member around the house. Thanks, Phil. Be alert to non-verbal signs if someone, as I said, can ask to go to the toilet. And these can be simple things like if they start fidgeting, their facial expressions, or just wandering around as if they're in search of something. And I'm sure you'll get to know your loved ones' non-verbal signs that they're needing the toilet. Make sure there's a non-slip mat on the floor by the toilet, and attend to any leakages and spillages on the floor, just in case they're at risk of slips and falls. Try putting a bright sign on the door of the toilet with words and or pictures, often if their vision isn't that great, or they've lost the ability to read things that well. It can help them to locate the toilet easily, or just leave the door open so they can see it if it's within their line of sight. What we're looking at is easy strategies at the moment in the early stages, so it makes things like going to the toilet a bit easier for them. And maybe if they see the toilet, it's easier for them to ask for it. Sorry, Phil, on you go. Nighttime can be particularly disorientating because it's much quieter, it's darker. So motion sensor lights, which come on when they detect movement, for example, in the bedroom, in the hallways, but not too bright so that they startle the person and scare the living daylights out of them. A dimmer switch for low-level lighting throughout the night, so it's a nice low-level light so that they wake up. You don't need to have the motion sensor light. Urinal bottles are available for men and for women. Women are, surprisingly enough, or a commode in the room, so that you can have it by the bed so that you don't actually have to leave the bedroom. Try and avoid drinks from around 2 hours before bedtime, so that they're not going to have to get up through the night if they don't want to. Caffeinated drinks can make you want to go to the loo, so decaffeinated tea and coffee is fine, as they make you want to go to the toilet more, as I just said. If you're going to reduce drinks prior to bedtime, please make sure they're fully hydrated during the day, because that can cause issues with hydration and issues with constipation, as I said earlier. But sadly, eventually continence wear will become necessary, and this can be pads and or sometimes a catheter, but you can get advice from your occupational therapist and district nurse or specialist continence nurse regarding that. Thanks, Phil. Going on to personal hygiene, again, as I mentioned before, an occupational therapist can assist you with aids and adaptations to make things a lot easier. That could be things like a bath or a shower seat, and handrails for the bathroom. Always good to stick to a routine. So if they were used to having a shower or a bath, stick to a shower or a bath. If they were used to, showering or bathing in the morning, it's always good to do that. Excuse me. Try and use familiar things that they've always been used to, the same sort of products, such as the same scents, the same makeup, the same deodorants, and allow them to do as much for themselves for as long as possible. I know it's a lot easier for you to do things for them because it gets done much quicker. But one, it's difficult for them to have things done to them. It gives them a lot more respect if you let them do things for as long as possible. It retains that ability for them to do things as well if you allow them to do things as long as possible. It's all about being respectful. Try and use, excuse me, use loose clothing. That makes it much, much easier for the person to do things themselves. Zips and buttons are really too fiddly. And if you are laying out their clothing, try and limit it to 2 outfits rather than say, what would you like to wear today? It's easier if you say, would you like to wear this one or this one? It's still being respectful, it's still giving someone a choice, but it's limiting those choices. Another challenging thing that families find is managing their expectations. They may no longer, sadly, be able to have a bath or a shower simply because of the way the home is laid out or the fact that the person can't get in or out of a shower. And we have to facilitate that. It could be that the person then has to graduate into having a strip wash or sadly having a bath in bed. The main thing, as I alluded to earlier, is please don't rush the person. That's really going to make them much more agitated, and if they are going to stiffen up, they will really stiffen up. It makes things much more difficult. And I'll go on to talk about myoclonus and the startle reflex, and actually rushing someone will make this much, much worse, but I'll talk about that later. Thanks, Phil. Finally, continence and personal hygiene are really, really complex. And if you think about the actual process that you yourself take individually about if you miss out one step of the toileting process. So if you miss out that one step of actually stopping going to the loo before you pull your pants up, that is an absolute catastrophe. So it only means if you just forget one step for catastrophe to happen. So just bear that in mind when you are doing all those things. Take it slowly. Don't rush things. Stay safe. Contact professionals to get help, whether it's with equipment, adaptations, or carers to help you out. And please don't be afraid to ask for help.
Lovely, thank you, Margaret. Okay, so now I'm going to go on and speak to you about mood and behaviour. So mood being a state of mind or prevailing emotion, and behaviour being the way that somebody acts or behaves. So as we know, prion disease can affect people's mood and behaviour and make them feel and or behave in ways that are very different to when they were well. And can actually lead people to do things that they never have dreamt of doing, would be horrified that they were doing it prior to becoming unwell. Now, as I said, there are various types of onset in CJD, and there is a behavioural onset as well. So this may be the first symptoms that you recognised in your loved one, is that their behaviour becomes more erratic. Mood disorder is very common in prion disease. It can be manifested in things like depression and anxiety, Now, it can be a direct result of damage to parts of the brain that regulate the mood, for example, the limbic system, that's known as neurogenic cause, or the result of awareness and recognition of the deficits and impairments that the person's undergoing. So that kind of self-awareness and the effects that that has on the way they feel about themselves, and that's known as psychogenic. One of the causes of changes in behavior is this loss of inhibitory neurons, particularly in the frontal cortex. And that can basically lead people to become more impulsive, less inhibited, and that can be manifest in aggressive behavior or inappropriate or restless. And as I say, potentially causing people to act in ways that they would never have dreamt of doing when they were well. So I think it's really important to consider behavior as a form of communication. As people's actual verbal communication becomes increasingly impaired over time, behavior can actually become increasingly a form of communication. And I think it's important not to necessarily put changes in behavior solely down to the diagnosis of CJD itself, and look at other reasons why somebody's behavior might have become erratic or agitated, or any changes that you may have witnessed. There's something called diagnostic overshadowing, which is basically where the diagnosis itself becomes blamed for all of the changes that you're witnessing, and it can lead to other things being overlooked or missed. For example, behavior can be an expression of unmet needs. So consider things like, is the person in pain or discomfort? Are they hungry, thirsty? Or is the environment itself causing somebody to behave erratically? For example, is it too noisy? Is it too bright? Is it too cold? It can be caused by an undetected or untreated infection. So I would say if there's a sudden acute change in behavior, it's always a good idea to notify your healthcare team or GP to come and rule out causes of infection, which may be treated obviously with antibiotics, and the behavior may improve as a result. It can be the result of distressing hallucinations or delusions, thoughts and beliefs that, and seeing and hearing things that aren't actually there. Can sometimes be a result of loneliness and boredom. So people aren't getting the kind of sensory stimulation that they need, and they've got all this sort of pent up energy and nothing to do with it, and so might act out as a result of that. Sometimes frustration and these sort of psychogenic, going back to the previous slide, realization that somebody's actually sort of losing control of their skills and functions and memories and things, and the frustration that can come from that can lead people to behave erratically, and feeling anxious about the changes that they're seeing in themselves. Poor sleep is a common symptom in itself of CJD, and that can actually change people's behavior going forwards. Constipation can cause people to be a bit agitated, so keeping an eye on bowel movements and things over time can be useful, and making sure that people are staying regular. And also changes to routine can be unsettling for people. Sometimes people can be really well held, if you like, by a routine, and so they come to expect certain things to happen at certain points during the day, and changes to that. For example, it could be a visit from a healthcare professional or friends or family, and things that just throw the routine out of sync, and that can actually cause people to become a bit more agitated and things. So it's quite useful in that regard to look at what some of the antecedents, if you like, or the causes or triggers of changes in behavior might be, so that you can limit them in the future. So now we're just going to have a little look at a quick sort of flow chart. So if you're concerned about changes in behavior that you're witnessing in your loved one. So first thing to consider is, does the behavior pose a risk of harm to the person or those around them? Obviously, there are some aggressive behaviors, violent behaviors that can pose a risk of danger or harm to themselves or others. And obviously, in those circumstances, if you feel it warrants it, don't be afraid to call 999 and get actual help from emergency services, be that ambulance or even police in extremis. Now, obviously, the threshold for that would be quite high, but it's worth bearing in mind that you know, those emergency services are there to make sure that everybody stays safe. Trying your best to remain calm and patient is really quite important. So obviously getting angry and agitated yourself will only inflame the situation, as it says there. So trying to notice if you're starting to become angry, it's all about your own emotional intelligence, and perhaps going to a different room to calm down, and perhaps using a breathing technique. There's a really simple breathing technique that I find useful, which is to breathe in for 4 seconds and out for 6 seconds, and count those seconds as you're doing it, in for 4 and out for 6. And there's actually evidence to show that people actually make better decisions and choices having done a breathing technique and oxygenating their brain better, and just taking that moment to calm everything down. You're more likely to make a rational and good decision going forwards about how to manage the situation. Requesting an assessment from the healthcare provider like the GP. We spoke previously that sudden changes in behaviour can be caused by infections, pain, or side effects from medication. So it's important to rule these things out and to avoid that diagnostic overshadowing, as I said earlier. Thinking outside the box, not blaming it all on the diagnosis of CJD alone. And as we've also touched on, is the behaviour a form of communication or an expression of an unmet need? So what could the person be trying to communicate through this behaviour? So it's about taking on the Columbo approach and getting out the magnifying glass and sort of having a think about, well, you know, could the person be too hungry, too hot or cold, uncomfortable, and so on and so forth. Now, if you're struggling to get to the bottom of what it might be that somebody is trying to communicate, then you can always enlist the help of myself or Margaret or the rest of our team to help you to think about that. Trying to identify the causal trigger of the behaviour, any changes to the normal routine, new people involved, or anything else that happened right beforehand. Was it an episode of personal care? Is it on movement? Is somebody when they're being moved, for example, for an episode of personal care, is that eliciting an aggressive or agitated response? You know, so is there maybe some pain associated with that could be treated, for example? Or is the person experiencing distressing or frightening hallucinations that they're fighting out against? And we do have treatments that can be useful in those circumstances as well. So again, reach out for help. Do let us know, and we can try and help you get to the bottom of what might be going on. And trying to stick to a routine as far as possible. Again, going back to that point that a routine can be a real source of comfort, and to try and include some sort of gentle activity in the day, tailored to what the person liked before becoming unwell. Obviously, with any adaptations that might be necessary to remain safe within the current limitations. So it's about sort of creating a nice, calm environment where somebody's engaged in some kind of gentle activity. So if you like, they haven't got the bandwidth to become agitated because they're sort of concentrating on something that they're enjoying doing. Even if it's maybe something like getting some paints out or something, or doing a simple jigsaw or something like that. And do bear in mind that it can be a source of solace to some that often we see a spontaneous improvement in behaviour in people with a diagnosis of CJD. It's because these symptoms do fluctuate over time. They wax and wane, and actually improve in a substantial proportion of our patients, even with no specific intervention. So sometimes it can be a case of sort of waiting it out and making sure that everybody remains safe in that over that episode. So just bearing in mind that it's sort of part of the natural disease process, and but the important thing is not to sort of suffer in silence, and do reach out and get the help of your healthcare team. So mobility and coordination, Margaret, thank you. think you might be muted, Margaret.
Sorry, it keeps muting me. Right, mobility and coordination. We'll talk about this mobility and coordination within prion disease.
Sorry.
All right, that's okay. So if we talk about some of the movement disorders within prion disease, before we actually talk about how you as carers can assist and manage these conditions. If we talk a little bit about ataxia, what is ataxia? Well, it's a lack of muscle coordination, which affects walking, speaking clearly, swallowing, and other activities that require some of the fine motor control, such as writing. Myoclonus is that sort of sudden, brief, involuntary jerking of a muscle or even a group of muscles. And the exaggerated startle reflex. And when someone has this exaggerated startle reflex, you might often see he or hear us talking about this startle reflex. And the patient may look really fearful and may actually recoil from touch, sound, or when someone approaches. But we're anxious to reassure you, it's actually a reflex, it's not an emotion. And the reason I mention these things is you might hear your healthcare worker or your doctor actually mentioning these words, ataxia, myoclonus, and an exaggerated startle reflex. And it's just so that you understand what these words mean. Okay, Phil, thanks. So when we're talking about managing ataxia, again, a referral to the occupational therapist for assistance with aids and adaptations. A referral to SALT, you might hear us talking about SALT. What we mean by that is a speech and language therapist. But don't rush your loved one. Ataxia can be really frustrating and debilitating. You can start by just using clothing that's simple to wear. No buttons and no zips, as I mentioned before. Try and use cups with lids and finger foods, sandwiches, easy to eat foods. It just makes life a little bit easier for them when they can't manage to pick things up or they're starting to spill things. And again, we're talking about in the early stages of this condition, just to make life a little bit easier. Some of this, simple solutions that you might just not have considered are the easiest. So don't rush and take your time achieving goals and completing tasks. Just to slow things down. Try and avoid flashing lights to avoid the startle reflex. Avoid sudden noises like banging doors, shouting, phones ringing, turn the volume down on your ringtone. And try and avoid approaching someone from behind. Try and speak quietly to them and let them know that you're there before you actually confront them. It's a good idea to take care when you're feeding the person, as they may startle when food and drink is moving towards them. And just be aware that they may startle so that you don't startle as well as when they startle. And as I said before, use closed lid cups, or sometimes a sports bottle, and that gives them that little bit more independence before you have to start feeding the person. It's a good idea if they're sitting on the chair themselves, just to keep things like the remote, the telephone, a call bell, all within easy reaching distance, because they might struggle when they've got ataxia to reach things quite easily because their arm movements aren't that well controlled. And the most important thing that I can ask you to do is to reduce as much external stimuli as you can. And by that, I mean noise, sound, changing of lights, as much as you can, just to keep things lovely and quiet for the person. Now, we're going to talk a little bit about falls prevention, and the reason for that is the biggest, I'm quite sure you're aware, the biggest risk for someone with poor mobility is a fall. So again, get a proper assessment from the occupational therapist. But what we will talk about is a few things that you guys can do. Clear all rooms of unnecessary furniture, rugs, and clutter if you can. Now, I'm not asking you all to throw things away or get rid of things, get rid of your very precious things. And if you don't have anywhere to store all these things, you know, you can rent as a storage. There's loads of storage facilities that you can use to rent, but try and clear them of as much clutter as you can. Try and ensure there's as much good lighting around as possible, because people's vision starts to go as well. Good fitting footwear is really, really important. Can't stress the importance of that enough. Shoes are often better than slippers, even indoors, good fitting shoes. Non-slip mats in the bathroom goes along with not having any rugs in the sitting room. Be aware of why the person might be restless and try and address that. Phil touched on that a little bit earlier. Are they thirsty? Are they hungry? Are they bored? Do they need the toilet? So they can stop, you can prevent unnecessary wandering about. Ensure the furniture's at a good height for getting up and down. You can talk to the, you can talk to the occupational therapist about getting seat raisers for your furniture. Just make sure they're on a chair that's the right height. You can get sensor pads for either on the chair that they're sitting on the floor, or on the doors. Again, talk to your occupational therapist about things like that. Adaptations in equipment such as grab rails, riser recliner chairs, wheelchair, walking aids, all make life much more easier for your loved one and for yourself, which is why you really need to get a proper assessment from your occupational therapist, not just once, but get reviews constantly. And if you haven't had a review recently, talk to the nurse that's involved. That could be myself, Phil, Blair, any nurse that's involved. Phil, thanks. So, movement disorders are complex, which, if severe, may need pharmaceutical intervention. And this needs to be discussed with your clinician, and it's not something that we're going to discuss tonight. They're debilitating and frustrating for the patient and the carer. People with movement disorders are at extremely higher risk of falls. Simple precautions that I've mentioned can reduce this risk greatly. There are simple available aids and adaptations from appropriate professionals that can make your life easier for the person with movement disorders. So seek help as soon as possible. Thanks.
Lovely, thank you, Margaret. Okay, so moving on to eating and drinking. This is the last of the 6 domains. So eating and drinking is actually a really complex act that we all take for granted, but it actually requires the coordination of about 40 pairs of muscles, and much of the central and peripheral nervous system is actually involved. So obviously with the effects of CJD being quite widespread, or very widespread over the central nervous system, those parts of the brain that are involved in bringing food and drink actually to the mouth in the first place, but then the process of chewing, mastication, and then moving the food to the back of the throat and initiating that swallow is a really complex act. In actual fact, the chewing and the movement of food to the back of the throat is actually a conscious act. It's not an automatic reflex. So that's why we find that people can be sort of chewing food for a very long time or holding food in their mouths. We call pouching, which we'll have a look at a little later. Over time, the ability to actually swallow safely becomes impaired. It's called dysphagia, and dysphagia can have a number of very troubling complications, which we'll have a look at in a moment. So really, this is just a table looking at the impact of prion disease on eating and drinking. Now you'll see that so many domains, if you like, of that are controlled and coordinated by the brain are affected by this disease, including memory, cognition, sensory loss, vision, dependence, mood and behavior, and motor function. And each one of those impairments can lead to outcomes such as forgetting if someone's actually eaten and drunk in the first place, actually sequencing the task of not only preparing but also eating a meal. Requires quite a lot of attention and concentration to get right the way through a meal, and you might find that somebody needs increasing sort of supervision and prompting to stay on task and actually get to the end of a meal. And actually, as the disease progresses, actually understanding the meaning of food and drink and actually recognizing it as food or drink in front of them can become impaired. Now, overeating can be a problem. Eating non-food stuffs as well can, in some people, become a problem. So requires a lot of supervision. Over chewing, pocketing or pouching food, spitting, and having that sort of oral control of the coordination as food is manipulated within the mouth. Having this sort of spatial awareness to actually get food from the plate to the mouth can be challenging. Using cutlery and drinking vessels can become increasingly difficult. Actually, mood and behaviour has a part to play here as well. Sometimes people can become suspicious of food and may think that it's been poisoned, and they might feel that the way that they're feeling is as a result of having eaten poisoned food and things, and can become quite anxious around food as a result. Food preferences can also change. People can start erring towards sweeter foods quite commonly, and that's looked at as part of the diagnostic workup for this disease. And actually having the motor function, so actually being able to bring about purposeful and coordinated movements can affect someone's ability to eat. Myoclonus, as Margaret was saying, can make it really difficult to actually get food to the mouth. And actually, the consequences of this can lead to a compromised airway, and we'll look at what the possible consequences of that can be in a moment. So these are some of the signs of dysphagia. Sorry. Things to look out for in your loved one, that their swallow might be starting to become impaired. It's really important to keep an eye out for these things, such as coughing and spluttering whilst eating and drinking, having a sort of wet voice or difficulty clearing one's throat, or sort of wheezing after eating, having difficulty chewing and swallowing it, just taking much longer, drooling and salivating more, and not being able to manage one's saliva in the mouth, frequent throat clearing, perhaps regurgitation of small or large amounts of food, and actually being left with food residue in the mouth after a meal. And some of the consequences of this dysphagia, or the impaired swallow, are that some people can start losing weight, can become dehydrated, can suffer malnutrition. These can all have knock-on impacts on somebody's performance and overall health. Poor oral health, obviously, if food is left in the mouth after a meal, it can have negative impacts on people's teeth and gums and things. And respiratory problems, and this really is the most dangerous aspect, if you like, of dysphagia, is aspiration pneumonia, which is where food and fluids can end up going into the lungs, sort of down the wrong tube, so to speak, and that can have very serious consequences in terms of infection, and if left untreated, can actually go on to become a cause of death in some of our patients. So it's important to look at how we can manage dysphagia, and really it is a multidisciplinary team approach. So what we'd be looking to do is make sure that these various people are involved in looking after your loved one. So there's the speech and language therapist, and they can look at sort of modifying the texture of the food and fluids. So foods will become progressively more pureed to make them easier to swallow, less liable to be choked on, and fluids will become progressively thicker through the use of thickening agents, so that it's easier for the swallow reflex to kick in and bring that hydration to the stomach rather than it slipping into the lungs. The occupational therapist can look at any changes to the environment, and also any kind of tools and utensils that can be changed, maybe through the use of kind of sippy cups or large handled cutlery and various other sort of adaptations that can make meal times a bit safer for people. And a dietitian may need to become involved as well. Sometimes if people's eating and drinking has tailed off, then they can look at providing supplements, so manage that risk of malnutrition. And they also manage artificial nutrition and hydration if a person goes on to have nasogastric or a rig inserted, and we'll have a look at that in just a moment. So here's some tips for feeding for carers that can be really, really useful to reduce the risk of dysphagia and to promote a sort of successful mealtime. So sitting somebody upright to allow gravity to bring the food into the stomach as opposed to going into the lungs and things. Reducing distractions, so maybe turning off the TV, closing the windows if it's noisy outside. Just get somebody to sort of concentrate as much as possible on the task in hand. Don't rush, which I think is a bit of a theme of this evening's presentation. Using small mouthfuls and trying to have a sip of drink between mouthfuls to help to clear the mouth. Eating little and often can sometimes be useful, as opposed to having a huge meal put down in front of you. It can be useful to sort of break that up. Contrasting tastes and temperatures can promote a safe swallow as well. So particularly tasty things, whose sort of fruits and curries and things, and it's things that elicit a sensory response, so that the person sort of knows that they've actually got food in their mouth, and they can sort of manipulate it appropriately. And also temperatures. So you'll often find that something that's particularly cold, maybe ice cream, will elicit a good strong swallow as well, and also things that are hot, but obviously within safe limits on the hot things, to avoid a burnt mouth. Checking the mouth is clear once the food has been finished is useful as well. Again, you don't want that food residue to stick around and breed bacteria that can be bad for your oral hygiene. So thinking about your twice daily mouth care and making sure that all parts of the mouth are included in that. So not just the teeth, but the tongue and palate can also be cleaned to make sure that's all nice and clear. I did want to mention artificial feeding. This is obviously the delivery of nutrition and hydration by way of artificial means, typically a nasogastric tube or radiologically inserted gastronomy, otherwise known as a rig. Now, my colleague Kirsty McNiven, who's a clinical research nurse, who I need to thank for helping putting together these slides on eating and drinking this evening. She's very much a kind of specialist in our team when it comes to eating and drinking, having been the lead author on a paper on artificial feeding in patients with the advanced stages of prion disease that was published in Brain Communications a couple of years ago. She actually carried out this study that was published, and what she found was that artificial feeding did indeed prolong the life in the advanced stages of the disease. So typically in the kind of akinetic mute, so non-moving, non-communicating advanced stages, as it says, of the illness. But she also found was that it didn't really contribute to somebody's quality of life. So if you like, their life was prolonged in this very advanced stage. But she also found that it came with significant risks and disruption to somebody's routine and things, and it can involve a number of hospital admissions, comes with the risk of infections and other things that can lead to undesirable consequences that can be avoided. And as a result of this, we don't routinely recommend artificial feeding in people with CJD. In fact, very, very rarely. think that it's probably not in somebody's best interests to undergo the possible side effects associated with artificial feeding to prolong that advanced stage of the disease. And what we do tend to recommend at that stage is that we adopt a risk or comfort feeding approach, which is where we're still attempting to provide a nutrition and hydration orally in smaller amounts, in the knowledge that somebody's swallow may be impaired, and so there is a risk of aspirated pneumonia. But while someone is able to take some food and drink, then yeah, that is the preferred approach at that stage. And finally, and quickly, because I know we've got a question and answer session after this, I wanted to touch on a little bit of general carer support. So looking after yourself whilst you look after others. And this is very much based on the premise that you know, we're always encouraged to fit our own oxygen mask on a flight, aren't we, before we turn to help others with theirs. And it's so important that we look after ourselves as carers, so that we're able to optimize our capacity for caring for loved ones. Now, it's well recognized that being an unpaid carer can be exhausting, stressful, upsetting, and relentless. And there's lots of evidence to show that it can have all kinds of negative impacts on people, including stress and low mood, which obviously negatively impacts the carer, but also the patient themselves as well, because it does really severely undermine somebody's ability to provide sort of good quality care. But on the flip side of that coin, with the right support, caring for a loved one can actually be a really positive experience, and one way you can really show your love, strengthen relationships with the patient and their family and friends, and undergo personal growth yourself. Obviously, it's not something that anybody would choose for themselves, but you know, there is the potential for some silver lining. Now, it's really important, and again, this is a real theme of the evening, is don't suffer in silence. Reach out to the health and social care professionals involved, be that the National Prion Clinic or Blair and Margaret, and ask for information, guidance, support, signposting, practical help. Speak to family and friends, people you trust for emotional support. It can be really useful to speak to people that you know well, who can provide that sort of reassurance and help you get to a point of acceptance for the situation that you found yourself in. Equally, speaking to people, health and social care professionals sometimes can be more beneficial, because you know, you're able to speak openly and honestly to them in confidence. Obviously, contacting a charity specifically set up to support carers. We'll have a look at some of them in just a moment and some of their contact details. And obviously a disease-specific charity like the wonderful CJD Support Network and all the great work that they do. And also that there are other disease-related charities as well, like the Alzheimer's Society or Dementia UK. Obviously, CJD itself is a form of dementia, albeit a rapidly progressive form, that they should be able to provide you with some help and assistance as well. There's also a carers assessment introduced by the Care Act of 2014, making it a legal duty for local authorities to offer this carers assessment, so that people are aware of what sources of support and help people have access to through the local authority. And you can request that yourself directly, or you can ask your allocated nurse to assist you with that. And it's in recognition of the fact that being a carer can just be one aspect of somebody's responsibilities in life, and that you know, you can really be juggling a number of different balls, and caring can just be one of them. And the carers assessment is really to look at how the local authority can help you to keep all those balls in the air. Carer centres can be really useful as well, an excellent source of support, information and advice. There's a link there which can help you to actually find your local carers group. And domiciliary care, Margaret's touched on this earlier on, but it can be increasingly difficult to look after somebody yourself as an unpaid carer as the disease progresses, or at any stage of the disease in actual fact, as the person becomes increasingly reliant on others to meet all of their care needs. So accepting domiciliary care can be a very good idea, and you must speak to your allocated nurse about how you might go about accessing that domiciliary care, which can be provided either through the local authority or under a scheme called NHS Continuing Healthcare, where your local clinical commissioning group will assign a care manager who will help to set up a package of care and also fund it if continuing healthcare is available. Respite is also a useful thing to bear in mind. Caring for people is tiring, and the stress and tiredness that can come with that can make it hard to remain calm and composed in challenging situations. You bear in mind that respite is a really good chance to either get a paid carer to come in for maybe just a few hours, to give you time to go off and do something for yourself, whether that's just have a nap or go for a walk or do something which is really focused on you. Using daycare centres can be useful for some, not everybody, particularly in the earlier stages of the illness. That can be useful, or a short stay in a care or nursing home, be that a week or 2 weeks, just to give you a significant amount of time away from that caring responsibility, so you can have a real good break, and do talk to, again, your allocated nurse about how you might access that. So I'm preaching to the converted here, obviously, but the CJD Support Network is the only UK charity providing emotional and practical support for all strains of CJD, and for those who are at greater risk of CJD. And their helpline there is open 9 till 9 every day for information and support. And an excellent source of information through their fact sheets and newsletter as well. And very quickly touching on benefits that are available to carers. So you might be eligible for one or more state benefits to help with the costs and potential loss of earnings. For example, carers allowance, which is means tested. You have to earn less than or equal to £128 after tax to be eligible for that. Carers credit can help with gaps in the national insurance record for your state pension. Carers premium is actually automatically added by the DWP if you're already in receipt of certain benefits, and there's a link to a calculator there, which Beth will send out to find out what you might be entitled to, and another link on how you can actually go about claiming those benefits that you might be eligible for. And this is a little slide on some sources of help, specifically to carers. And really, I'm just going to finish with this last slide, which reminds you to take care of yourself, and that sometimes you get so busy taking care of others that you forget that you are important too. So do remember that. So that is the end of the presentation. Thank you so much for your attention and concentration this evening.